Hi, everyone. My name is Virva. I volunteer with PSC Partners Canada. I'm from Toronto, and I'm a PSC patient myself. We're here to talk about liver transplantation, the why, how, and when. We're on the transplant track. When I was asked to help facilitate this session, little did I know that my own first transplant consult would be earlier this week. So talk about being close to the subject matter. Um, so I'm going to introduce our esteemed speakers today, and they both indicated that they want this to be a fairly interactive session. So once they're done speaking, if you have questions, really don't be afraid to bring them forward. So first up will be Dr. Espen Melum, MD, PhD at Oslo University Hospital. Professor Melum works as a hepatologist at Oslo University Hospital, specifically focusing on PSC and transplant patients. He's also leading the experimental hepatology group at the Norwegian PSC Research Center, focusing on basic and translational studies with the aim of understanding the disease process in PSC. He trained in gastroenterology and transplant hepatology at Oslo University Hospital, Rikshospitalet, where he's now seeing patients as a consultant transplant hepatologist, focusing on PSC and transplant patients. We also have Dr. Richard Green with Northwestern University Feinberg School of Medicine. Dr. Richard Green is a professor of medicine and hepatologist at Northwestern University with a clinical interest in the medical care of patients with PSC and other cholestatic liver diseases. His research focuses on the molecular mechanisms that cause liver disease, applying this knowledge to the development of novel therapies for patients with PSC and other liver disorders. Dr. Green is a member of the PSC Partners it's that kind of day. Scientific Medical Advisory Committee, otherwise known as SMAC, which I think is a fantastic acronym. So welcome to our two speakers.
So thank you for that very kind introduction. It's great to be here. I want to thank PSC Partners for inviting me, and also both of the patient centered meeting here and also to the preceding scientific part, which we had two really great days discussing opportunities and challenges in PSC research. But the topic for today is liver transplantation. And we'll talk about the why, how, and when. We'll go through a lot of different aspects. I will first go through the general aspects of liver transplantation in PSC, and without touching upon the US-specific issues, that will Dr. Green do afterwards, because obviously I practice in Norway, so it's a little different. But we have transplanted a lot of PSC patients, so I'll tell about our Nordic experience. And then I hope we can have an interactive discussion. We're open for all your questions. No questions are stupid. So please think about things you want to discuss with us afterwards. So we'll go through the topic then of PSC and liver transplantation, our Nordic experience. Then I will go through the common indications. When do we list the patient for transplant, and all the different considerations we do then, just both the doctor and together with you as patients. Then we talk about the timing, which is always difficult. When should you offer a transplant? Then we talk about waiting time and the transplant itself. And I'll touch a bit upon post-transplant challenges with anastomosis problems, rejections, and the risk of getting recurrent PSC. So is there any guidelines for this? You cannot put up any general guidelines, because this is very region and country specific, but it's but we'll say what is our practice in Norway, and Dr. Green will tell about how this is from a US perspective. So PSC and liver transplantation, it's unfortunately it's the only definite treatment. I think a hope in some years, I will say here, that this is the treatment if all the other treatment options fail. But PSC is a well-established indication. Survival is very good, 5-year survival over 80 to 90%, obviously depending upon the state of the patient you transplant. This is really in the upper range of transplant indications. So we want to bring the patient from this stage with a PSC liver to a healthy transplanted liver. The listing and timing is according to the transplant program and timing according to their criteria. So I'll tell about our Nordic experience. I just had to show this map to show where we're located, to tell about our experience. We're located here in Oslo, Norway. We collaborate quite closely with our Nordic colleagues in Denmark, Sweden, Finland, and we also, even though it's a Baltic state, we include Estonia, and we helped Iceland, the people in Iceland doing their transplant at our centers. So we're a large region, 28 million inhabitants, 6 transplant centers for liver. All of our centers have separate waiting lists, but we help each other out when there's a highly urgent case. And another good thing is that we also share surplus organs, so they're not wasted. If we cannot use it in Norway, then we help our Danish or Swedish colleagues, and we give absolute priority to urgent cases across this region. And what's special about this region is that we transplant, and have done since the start of the program, we transplant quite a high number of PSC patients. It is competing with alcoholic cirrhosis and hepatocellular carcinoma in being the most common indication. It's around 15%. It was number 2 in last year, but the period before, you see that it was a leading indication. So it's one of our leading indications for transplant. And I think this contrasts programs in the United States, where the percentages are much around 5%. What is the reason for this? It's we do have more PSC in the Nordic countries, and we're able to offer transplant to more patients since we have less other liver diseases like alcoholic cirrhosis. So how are these people faring then in the Nordic countries? Just note that this is a survival curve, and here we have years along the x-axis and the cumulative survival here on the y-axis. And note that this is a very long survival curve, closing now into 40 years. So it looks like it's a little steep going down, but it's really not. Normally you see this cutoff at this stage, and still liver transplantation doesn't give eternal life for any of us. So you expect some patients to die, of course, but you see that they're doing very, very well. These are the PSC patients then compared to patients with alcoholic cirrhosis and hepatocellular carcinoma. So here it's a very favorable diagnosis going into transplant. So looking at the indication for transplant, I think I take one of the ones I would say is the easiest first. This is when cirrhosis has developed in PSC patients. Then you're kind of in the same setting as we are with all other end-stage liver diseases, with indications being recurrent ascites, variceal bleeding, hepatic encephalopathy, which is when you have ammonia building up in your body, giving this confusion situation. There's spontaneous infection in your ascites in the abdomen, and problem with the coagulation. And here, general recommendation is the same. We do same as said in the US, referral to a transplant center when what is called the MELD score, which I think most of you relate to. If as a transplant patient, is a way of estimating the degree of liver failure, which is used for selection of patients here in the United States. So I would say this is the kind of the easy indication, because it's largely the same as for other chronic liver diseases needing a transplant. Then another indication, which is more difficult, that's recurrent cholangitis. If you experience numerous recurrent cholangitis requiring hospital admissions or antibiotic courses, this can be an indication for transplant. Normally, we would then first assess the bile duct with MRC and consider endoscopic therapy in several rounds before we go on to transplant, because you want to put the transplant further out in time, so you have longer time with your original liver. It always helps in this decision if there are other factors like declining liver function, and often we see patients which have both, and that makes our decisions easier. Then intractable pruritus, and I'm sure many of you or the persons you're caregivers for experienced intractable pruritus, and my patients normally tell that this is the most bothersome symptom you can think about, and many of these patients have severely reduced quality of life, but normally it doesn't affect the survival. And the first point here is that we need to, of course, exclude relevant strictures in the bile ducts where we can intervene with endoscopic therapy. That is point one. We would like to see that the patient have tried drugs to reduce the itch and go through the list of different drugs. I know that there are different drugs that are licensed in different countries, but go through whatever you have of these conservative measures first. And often when these patients are referred to us, we discuss it together with our endoscopist, and we almost always say, let's give it a final try with endoscopic therapy, often at the same time starting the workup for transplant if it fails. And I think this really needs a close dialogue with the patient and the doctor to figure out how bothersome is this. What could you think? Okay, will you go into transplant, or can you tolerate? What level of reduction in quality of life can you tolerate? Which level of itch can you tolerate? Next, an indication which is not used here in the United States, but I think it's worth mentioning, and that is dysplasia in the bile ducts. We're not talking about cancer here, not cholangiocarcinoma, but these earlier stages which predisposes to development of cholangiocarcinoma. So when we have a patient with a suspicious stricture that we're blocking up, or also we have a suspicious finding on the MRIs, we do a brush cytology in the patients where we put up a small brush in the bile ducts, get out some cells, and have our pathologist evaluate them. And in the patients where we have like a clear dysplasia with high-grade dysplasia, or brushed twice with some months in between with low-grade dysplasia, we can offer them transplant and listing them. This is often a very, very difficult discussions with the patients, because they're often in excellent conditions. They live a normal life, and they really don't want to go to transplant. And this is of course a joint decision. This makes it easier if there's additional indication for transplant, like recurrent cholangitis or declining liver function. But this is a unique feature of our program, that we can offer this. And when we have transplant, looked at our patients, we did that 10 years ago. I think the picture is pretty much the same now. And looked on the explanted livers, we found dysplasia or actually cancer in some of them in 80% of the patients that we offered transplant based on dysplasia. The flip side of this is that, of course, we had 20% of the patients that we didn't find the dysplasia in the explanted liver. Most of these had additional factors which warranted transplantation, and none of them have come back and said that they regret it. But of course, we don't want that percentage to be much higher than 20%. So our distribution of indication for transplant is then slightly different. We have 40% of the PSC patients that we list are with end-stage liver disease. That will be the patients with cirrhosis and all these complications, more like the classical, like all other patients with liver failure. 40% is that what we grouped here as impaired quality of life, and this includes the patients with the pruritus and recurrent cholangitis. Of course, this is not only related to the quality of life, but it's a way of, you think you do the transplant to make their life more manageable. Of course, you can manage the cholangitis with repeated courses of antibiotics, but giving them a transplant, they can avoid this and all the hospital admissions. And 20% is with suspected dysplasia. as we just discussed. So then what about the timing? When should you do the transplant? I can just say one thing, it's difficult. You really don't want to do it too early, and obviously you don't want to do it too late. So as you know, the transplant-free survival for a PSC patient, if you look at the natural course, it's even though we would like it to be better, it's pretty favorable for the first year. So we want to let the patient live as long as possible with a native liver before we're really lifting them over here to also this favorable survival following transplant. But at what stage should we lift them over here? This is the big question. So what about when you then reach the decision of listing for transplant, which of course involves the discussion with the patient. It needs to be the right indications, the work with the surgeons, the discussion with the anesthesiologists, etc., etc. So what about then you go in for transplant? Then the waiting time, and that's a major issue, and that is highly variable, and it's center and region specific. I think we at our center is really spoiled. The typical patient at our center in 2022, this is all patients, waited for 57 days, which is very, very different from what you see elsewhere in the world. Of course, we do also have patients that wait for long. The longest waited for 552 days in 2022. But this is due to that we have better access to organs since we have less of other liver diseases, and this is the reason that we can offer transplant to patient with dysplasia and more of the patient with recurrent cholangitis. Then is the issue of living donor. Dr. Green will touch upon that. We don't need to do living donor for adult patients. We only do it for kids, so we don't have any experience with that. Then you need to have the right blood type. The liver needs to be of the right size. And there's also the issue of logistics. Where is the donor located? Where is the patient located? You need to really get that to work out. Then you also have some specific cases, especially in retransplant, with donor-specific antibodies, etc., which you put into the equation. So is everything fixed after the transplant? No, there can be challenges ahead also after transplant with complications. But before going through them, I would say that we can fix all of it. There is the rejections, which most people probably is what they're fearing in the start. There is really effective treatment, and but you know the PSC patients are at an increased risk. We might modify the immunosuppressive regime, which varies between center after a rejection period. We see problems with the arteries and the other vessels. So we can solve all of them. Almost all of them with interventional radiology. Very seldom we need to reoperate. The thing that can be noted is that this can give changes in the bile duct due to the arterial supply later on that can mimic actually PSC. Sometimes we have problems where the bile ducts are connected. We normally can solve that with endoscopic therapy. And when the patients are under heavy immunosuppressive regimes, there's a problem with infection, which we normally can handle very well. And there's also the long-term side effects of immunosuppression. But this is always managed, and it needs to be followed closely by your physician. Then is something I would hope I wouldn't have to talk about, but this is an issue that is currently heavily investigated. This is you can get PSC back in the liver and in the new liver. And this has been reported in up to 30% of the patients, depending a little bit on which patient series you look at. And the question is this the same disease or not? I think that's the unresolved question. We think it's the same disease. Histologically, it looks the same. And to really understand what this means, because the patients getting PSC probably have had PSC changes many years before they get the diagnosis, but because they're followed now so closely after the transplant, we probably catch this very early. So finding these changes early, what does it mean for the prognosis? And we're currently looking into all our patients transplanted with PSC and see through protocol biopsies and see really what this means. There's some risk factors. It varies between all the studies. The studies are quite small. It seems that it's important with level of rejection, donor-recipient matching, and IBD. But here this really needs to be better clarified. And the question about treatment, can this be treated? I hope that when we get a treatment for PSC, that we might want to keep PSC patients that are transplanted on prophylactic treatment with some of the same principles. And keeping the liver like this healthy PSC liver transplant and not going into this stage of recurrent PSC. So to summarize, PSC is an excellent indication for liver transplantation. We have super good results. The timing is difficult, close dialogue with your doctors. There's, as I pointed to, there's so big center and country differences, so you need to really relate to the center where you're receiving care. Recurrent PSC is seen in 30% of the patient, but I really would stress that the impact of this, at least the subtle changes, need to really be clarified what it means for the prognosis over the long term. Yeah, thank you, and then I hand it over to Dr. Green. Yeah, and then we take the questions after the two talks.
Thank you for that excellent overview of transplant and PSC. And welcome all to the conference. The one major difference that I'm going to talk about, which is not insignificant in any way, is in the United States, it's much more difficult if you are on the transplant list to get a liver. And as was alluded to before, if you're in Scandinavia, you don't need to do a living donor liver transplant. You can always get a cadaveric one. And unfortunately, that's not the case in this country. So I want to explain the system and end up with some optimistic ways that maybe we'll change it. So as many of you know, liver transplantation's a new lease on life, but you got to get a donor organ. And in this country, it's much more difficult than in Norway or any of the Scandinavian countries. And I want to go over the system, and I'm only going to have two abbreviations. I could bore you the whole time, but I think they're very important. One is UNOS. UNOS is the United Network of Organ Sharing. Basically, it's a nonprofit company that serves the nation's transplant system, and it's under the Department of Health and Human Services. It does kidneys, lungs, hearts, livers, all solid organs. It basically leads the network of transplant hospitals in organ procurement, meaning obtaining organs. It leverages data and advances to increase the number of available organs we can recover and transplants that can be afforded. It ensures patients across the nation have equitable access to transplant, which is not fully achieved, but it's getting much better. Again, there's been over 42,000 organ transplants last year. About 95, this is listing, it should be about 6,000 transplants, 95 listed, and a record number of kidney transplants. And UNOS actually has this is as of July, a list of how many transplants it's doing of all types, and it's well over last year. So that's getting better. So UNOS cannot do the logistics of organ transplant. They can't send someone out to harvest a liver or decide who needs to get it. And that's why the other important abbreviation is your Organ Procurement Organization, or OPO. These are also nonprofit organizations that they're responsible for obtaining, procuring organs for transplantation. And there's 56 different OPO entities throughout the country. They provide support to donor families, they manage the clinical management of donors, and they do public education. But they actually don't make the final decision about whether you get the transplant. They will offer it to a center, offer it to your to the surgeon if they're next in line, but it's a medical decision by your doctor whether to go through with the transplant. Because if you're very sick, you may take a marginal liver. If you're healthy, you may want to wait a while till a very good liver comes along, because all livers are not the same. So basically, the concept came around in 2000 called the final rule. Before 2000, people cheated. There was no standard in the country. They made their patients in ICUs, and maybe they were advocating for their patients. Maybe they just wanted to do more transplants, but it was very unequitable. So the final rule, which still holds, is in 2000. It's a national policy in the US that dictates the protocol for all cadaveric organ donations. Cadaveric means from a donor that's not alive. It's again under the Department of Health Human Services, and it's moved away from a system that was based on geographic areas with large donor banks towards a system that's more nationwide and based on patient need. And it's important to realize, and I'll say this twice, organ allocation does not increase the number of donors. The way we allocate organs doesn't increase the total number of transplants we do. It just prioritizes who gets them. And there's winner and losers. And we use a MELD system. And unfortunately, the MELD system it's a calculation. The higher your MELD, the more likely you'll get a transplant. But it's very dependent on your renal function and your ability of your liver to make blood clotting factors. And those tend to be preserved in people with PBC or PSC. So although the MELD is equitable, there is a little disadvantage to people with PSC, and there's ways around it I want to talk about. So since 2000, there's been 220, the acuity circles of organ donation. And as you can see, this is 75, 100, 300, and 500 nautical miles. And basically, if you have a patient who's donating, it goes to the first circle. If they pass it up, it goes centers to the second circle. If they pass it up, it goes to the 500-mile circle. And if not, it goes anywhere into the country. And this has been shown to be more equitable. Now, there's something called status 1. That's acute liver failure with no pre-existing liver disease. They get priority over everything, and no one with PSC will be status 1 because they have pre-existing liver disease. And the MELD and the PELD, this is model of end-stage liver disease or pediatric model of end-stage liver disease, is how we allocate organs. The higher the MELD, the more likely you are to get one. And the number 15 comes up just like in Scandinavia, because if you're a MELD under 15, it's unlikely that you will benefit from a transplant. There are exceptions I'll talk about. So again, MELD is the model for end-stage liver disease. It was originally made as a survival calculation. It's a severity of illness and mortality risk. And it's calculated on the albumin, the bilirubin, the INR, and the creatinine. And now we actually use MELD sodium, which is a little modification that's not important. Now in pediatrics under the age of 12, they use PELD, which is kind of the same system, but they get more points for younger age and for growth failure. And in general, this will favor a pediatric patient over an adult patient. Now, one thing that's essential for all organ transplants is your blood type. It has to be compatible. The other thing that's essential, and this is important in living donor, it has to be big enough, but not too big to fit in the recipient. So size and ABO blood type are the absolute contraindications. Now, there is something called exception points. Like I said before, there is some disadvantage in cholestatic liver disease when they first have MELD. So exception points try to equalize this. They give you additional points than your MELD would say. So with PSC in this country, sorry, let me go back. If you've been in an ICU twice over the past 3 months, if you have cirrhosis, and you either have a stricture that cannot be fixed, as was described before, or you have cholangitis with an organism that we really don't have antibiotics on, you get exception points and move way up on the list. The other priority for exception points is hilar cholangiocarcinoma. This is the type of cholangiocarcinoma people with PSC get. There's also a different kind of intrahepatic that I'm not going to talk about. So with recurrent cholangitis and infections and with cholangiocarcinoma, bile duct cancer, you do get exception points. So here's some data. This is an abbreviation you don't need to know, but it's actually the UNOS national data on transplant, and they put out a report every year. Now this is 2019. There's always a lag. There's no 223 yet. The 222 is just about ready to come out. So this is a little dated, but essentially the same. This came out in 2022. And this shows in America the new adult candidates added to the liver transplant list. And if you look, there's not a whole lot of difference between 2008 and the present time. There's a slightly more increase, but it's always been about 13 to 15,000 people added to the wait list. This is the number of all adult candidates on the liver transplant waiting list. Not who is listed, but who is listed in the year plus all the people who had been listed before, and that runs about 25,000. Again, no change over the past decade and a half. And this shows the overall deceased liver donor count. This is a cadaveric donor. This is the vast majority of liver transplants are done with patients who have died, and they take the organ out and they give it into the recipient, and that's actually getting a little bit better. But the other way to get an organ is with a living donor. And I'll talk a little more about this and maybe take some questions. Because living donor, it used to be living related donor, but it can be any living donor. We've had priests donate to parishioners. We've had Chicago cops give it to their partners. But it's actually been pretty flat, the number for the past 15 years. And it's been about 10%. So living donor liver transplantation could be essential for life and quality of life and life-saving in certain conditions, but overall it's not the solution to the donors. And why is this? Well, there's several reasons, but the main one is in order to donate, you have to have the right blood type and you have to have the correct size of your liver. And the donors have a mortality of about 0.2 to 0.5%. That's mortality. It's much higher than kidneys. So you have a healthy patient who's going to donate a liver. They're going to be out for 6 to 8 weeks before they're back. But there's actually a mortality. So we only give living donors if people need livers quickly and cannot get a cadaveric donor. Again, this just shows distribution of adults waiting for liver transplant by race. And unfortunately, this kind of reflects the rest of healthcare in our country. There's inequities based on race and ethnicity and socioeconomic factors, all of which are being addressed, but certainly are currently still problems. And this shows based on diagnosis. And I think one of the most important things is hepatitis C. That's a cute one. Hepatitis C, am I doing this, is the brown. And we got a cure for hepatitis C in 2015. So now people could have cirrhosis. We treat them with a hepatitis C, and they may not need a liver transplant. They usually don't, only if they develop a secondary liver cancer. And unlike Scandinavia, this shows the percentage of transplants that are in cholestatic liver disease, not just PSC, but PSC, PVC, and some pediatric diseases. And it's under 10%. And part of that reflects the commonality of this disease, how the prevalence in our country, but it also reflects the prevalence of other causes of liver failure. And this shows basically by blood type. You have to match a blood type. Blood type A is very good. In virtually every region, it's much higher. Blood type O, which is the most common blood type in the country, the problem with blood type O is O's can go to O's, they can go to recipients with A or recipients with B. They're the universal donor. So being type A or AB in this country really puts you much easier to get a transplant. And this doesn't really matter what the title is. There's like 4 or 5 similar grants. It just shows the inequity that still exists in transplants in this country. Florida now has the lowest MELD to get transplanted. The Northeast, it's much higher. And as you can see in the South, this shows patients who underwent deceased donor liver transplants within 3 years of listing, and it's about 85% in some southern places. It's much lower in other regions. So how do we increase the number of donors? Because this is what we really need to do. And I'll spend about 5 minutes on it, and then I'm kind of done. But public awareness and education. I don't know, probably many of you know who Walter Payton is. Walter Payton was a very famous running back, a hero in Chicago, and he died of cholangiocarcinoma. And the number of donor livers available in the region of Chicago almost doubled. It went up for 3 to 6 months afterwards. That was only public awareness. Similarly, our Secretary of State for the past 20 years, not the past year, his sister got a kidney transplant. So anytime you get a driver's license, you have to declare if you want to be a donor. It's not legally binding, but you can show it to the family. So public awareness is really important. So living donor liver transplant, maybe we can talk about this in the session, is really important for select individuals, but it really has not been the end-all cure for the donation, the number of donor livers. It's about 10%. DCD livers. Normally we do brain dead livers. Some people don't want that. So that's when we actually wait till the heart stops and there's no circulation. And unfortunately, those are less optimal donors. They don't do as well. Split liver donations, you can split a liver between a pediatric and adult. That helps a little. Extended criteria. In other words, there's now something that's going to have a fundamental importance. It's called normothermic liver perfusion. You can take a liver and you can perfuse it, say, for 15 hours, keep it alive. It actually gets better. And you can take, this is a new technology, you could take fatty livers, and high fat is an absolute contraindication to transplant because they do so terribly, and you can defat the livers. So this actually may prove to be a really important advance that we're going to see in the next couple of years. Presumed consent in Europe, you're presumed to donate your liver, your family can say no. Here you're presumed not to get a liver, your family can say yes. Stem cells, we will be making artificial livers in the next 50 years, but not in my time. Stem cell offers very good therapies often for liver diseases, but it's not the cure-all, and artificial livers are way off. And finally, the risk of financial incentives in organ trafficking. It is illegal to buy a solid organ in this country. Does it happen? Well, if it happens, it's very, very rare, but it's not always that rare outside of this country. Here, it's illegal. And what may be the most promising, and this is actually the Washington Post, is xenotransplant. This is about 2 weeks ago. They put a pig kidney in a brain dead man, and basically it worked 30 days later. So they use a pig because people eat pigs. We use pig valves. A lot of the ethics aren't really a problem, but xenotransplant has its own problems, and it's been very difficult to come along over the past 20 years, but it may really be showing ready for prime time, in which case there would be an unlimited number of solid organs. So basically, these conferences and your input to UNOS and the OPO will actually help change this. They're going to probably redo the allocation system. I think now it's out for public comments. Please feel free to do it because the presumed one next will be better for people, including PSC. So I'll stop right there.
Do we have microphones to be, okay. If you have questions, we can bring it around. While I go grab a microphone, I do have one question. My early knowledge about this process has been mostly about the recipient side, but I'm on, blood test number 42 or 43 that I'm seeing pinging into my patient portal. How do you have time to evaluate a deceased liver extensively enough for all the possible things that somebody could have?
Well, this is where the OPO, which is the 56 regions, is very, very helpful. They will get a donation. There's very rapid testing of viruses, hepatitis C, HIV, et cetera. And then they basically will call a center that is next up to get a liver. The center can either refuse it or can actually come and see the donor. Sometimes they do a biopsy. It's actually a very efficient system. Now, if ex vivo, liver perfusion works, you can keep those livers alive and actually improving for up to 15 hours. So that may offer the opportunity to send them anywhere in the country, which would really cause geographic distribution differences to go away. But it's kind of an art form, but it works.
Thank you. I see you have a microphone.
Testing. In Norway, how do you define recurrent infectious cholangitis as an indication?
Recurrent cholangitis.
Well, in the USA, it's defined as 2 ICU stays. How do you define it in Norway?
We don't have any like specific definition. It's a combination. We don't require ICU stays. Numerous antibiotic courses. Not possible to do any endoscopic therapy.
Can we temporarily emigrate?
If you can.
Can we temporarily emigrate? Obviously not. I'm just
No.
Yeah. So I should say that you could have in this country, you can get sick and have a terrible quality of life because you're getting recurrent cholangitis or itching pruritus, which is not a criteria here. And in people who have low MELDs under these criteria or are confused, have encephalopathy, those are ideal people that we may want to evaluate for a living donor. Their life's miserable, yet they have trouble getting a cadaveric donor. So that's who we target.
Yeah, and I think some of these groups that we transplant here, you can probably solve with the living donation programs.
But living donors seems to be only in a few centers, not all centers.
That's actually good. I mean, ideally, there's 6 centers in Scandinavia. There probably should be 10 to 15 in this country. And there was a huge study called the A2All study, and it shows that with living donors, there's a learning curve. Your center and surgeons had to do at least 20 till your survival got good. So less centers is better, but in virtually every region, there's centers that do both cadaveric and living donor.
I have a question regarding survivability rates. For years we were told, really horrible rates. And I'm sorry, I forgot your name, but you're showing up to 40 years, which is incredible. So what are the survivability rates in the United States and Canada? Is it similar?
I don't think the long-term survival rate should be different in the United States and in Canada. The reason that we have that long follow-up is that we basically don't lose the patient from follow-up. So we follow them. The very few that emigrate, we know about them. The rest we have the complete registry of. So I don't see this. I haven't seen any data saying that there is worse survival in the United States.
It's fairly comparable, and actually UNOS monitors this. There's kind of 2 survivals. One is organ survival. Do you need to be retransplanted? The other is patient survival. And if you get out to 5 years and you're doing well, then your chance of, just wear a seatbelt, don't smoke.
Right.
Yeah.
Thank you.
Hi there. Hi, thank you so much for your presentations. I have a question about the acuity circles for organ allocation. We live in Hawaii. We also live in Los Angeles. We've had to make a decision about where we're going to spend most of our time. The docs have all suggested stay in Hawaii because recently there's been some changes about allocation that Hawaii livers stay in Hawaii. And also the MELD score is much lower in Hawaii. So do you have any input?
The last you said is the golden question, because transplants go by how high the MELD score is. I'm actually not familiar with Hawaii per se, but from what you're saying, for one, it's more convenient. But if you're transplanting at a lower MELD score, that's in your advantage. We have people who actually go from Chicago to Florida because the MELD scores are lower. You can be simultaneously listed in two regions.
Right. Although I think we'd rather be waiting on the beach than in Los Angeles fog. So that also works for us. Okay, thank you.
I'll make a house call if
Okay, so my better half.
you're on the beach.
So you made a comment on one of the slides, I believe, that said that PSC has a greater potential to have a negative impact during a liver transplant. Is that true? And could you comment on that if it is?
That it is, so I think you would say, I probably didn't get that true, but PSC is a favorable prognosis compared to most of the other chronic liver diseases. If there is age limit,
In general, and it's center specific, over 70 is not, we start thinking, what is their physiologic age? We would much rather do a 75-year-old who's running every day than a 55-year-old who's cachectic and sarcopenic, meaning which is problems with people's cirrhosis. So there's no absolute cutoff, and we do a fair amount of transplant of people, young people in their 70s.
I have a question for you. So if you're a PSC patient and if your liver develops cancer, are you still considered to be a candidate for a liver transplant?
so do you think about cholangiocarcinoma or cancer in other places?
Yeah, I don't know if it, just a general question because I was.
It's a general question. Okay.
Yeah.
So if you're cancer and radically treated for a cancer somewhere else, we consider them for a transplant, yes. But not if there's a metastatic disease.
How long after a transplant have you seen PSC reappear, or how early?
How early? I think we've seen it as 6 months,
Within 6 months.
but that's not common. That's really not common.
I mean, the take home message is it's a good indication for transplant, and people generally do very well. It's not a virus that's going to reinfect the liver, and yes, it does recur in about 20% of patients. You always have the option of retransplantation, which no one wants, but it's a possibility. But if you're gonna, you don't want liver disease, but if you're gonna pick one, PSC does better than most.
Yeah, and I wouldn't, if I was transplant, I wouldn't go around fearing it. I think the reason that we diagnose so many is that we do it so early. This might be the kind of changes that regular PSC patient had like 10 years before the diagnosis.
And then Dr. Melum, you had said that when doing a transplant, you don't want to do it too late, you don't want to do it too early. If you meet the scoring criteria, what other concern is there with too early? What is
What is too early, that the total benefit is less. So if you like the MELD score, if it's below 15, you fare better without the transplant, waiting until you have the MELD score above 15, because there is some risks involved with the transplant regarding the surgical risks.
So the question I have is when it comes to getting listed, like I live in the Northeast and I'm listed at a place in Philadelphia, a hospital in Philadelphia. Do you recommend getting listed? I mean, you mentioned it before about getting listed at more than one place like Florida, but logistically, is that even possible? Because what I've heard is when you get the call, you have to be there like this.
Yeah,
So
I mean,
how can you make that happen?
some institutions make you move there, like if you're high on the list. I would definitely get listed at one institution before you start looking for other ones. But yes, I mean, the logistics of being 2,000 miles away do not allow you to stay at home and fly from Hawaii to LA. So that is a problem. But if you're willing to move and for a short period of time, including post-transplant, centers will do that.
Thank you.
Hey, thank you all for the
presentation. Could you share a little bit more on the exception points? And so with cholangitis and cholangiocarcinoma, how many points does that yield? And then I guess for me, because I don't know what the points do in
I
terms
kind of blew through that slide because it's a little confusing.
Yeah.
The way exception points are for PSC and recurrent cholangitis is you start out at 3 points below what the average MELD is. And exception points are for lots of diseases: polycystic liver disease, lung disease that occurs with it, liver cancer, and that tends to change. People with liver cancer didn't get enough exception of points, they changed it, then they thought they got too much, they drop it. But it does put the patient who has recurrent cholangitis really with a low MELD score up into where they should be. And then you get more exception points as you go on 3 months out, 6 months out, et cetera. Those are the main, you said cholangitis. For PSC, those are the main two. You know, there's many other, and they're like familial amyloidosis. They're pretty rare, and you can actually request in your OPO to get an exception for a certain disease. They virtually never accept it, just the accepted exception points.
So if I can just ask a question, seeing this MEL-based allocation system from the outside, you get the impression that you find something that is not equitable, then you correct it, and then it's overcorrected, and you correct for something else. Is there any process in the US that kind of to change the system?
It's constantly evolving. We used to do Share 35 from 2013 to 2020. Then we went to acuity circles. There's actually, and there's accumulating data. Actually, David Goldberg, who's here, does it, looking at how these changes affect quality of life and mortality, et cetera. So as we change it, we get more data and change it back again.
So it's not constant, and it's constantly
Right.
evolving.
I mean, there's bureaucracy and things lag and they're imperfect, but the direction is clearly more equitable distribution.
So we just have about 2 more minutes left in the session. I'm going to be hard about this one. So if anyone has any last questions.
So on your slide, it said for recurrent cholangitis, it required the ICU stays for the US.
You need cirrhosis and 2 or more ICU stays within 3 months, and then you have to hit the criteria of a very resistant bacteria or endoscopic criteria that they can't fix the stricture and you can't.
So that's for deceased donor only then?
That would be for deceased donor. We can do a living donor on anybody who we think would benefit from it. Keeping in mind, if we do a living donor, you have to be eligible for a deceased donor because you could have primary liver failure from that too. But it's really in the people who don't MELD high enough and can't get a liver and are sick, and that might be a good example. We will look for a living donor liver transplant. And the other advantage, there are disadvantages. The complication rates are a little bit different, but in people who can't get a good MELD and have poor quality of life or dangerous recurrence like cholangitis, that's an indication for living donor evaluation.
Thank you.
Not in Norway.
They just have so many livers just floating around.
Thank you for your presentations. Could you speak a little more to what you just mentioned about the complication rates being different between deceased and living donors? I also had questions about, are the survivability rates and the recurrence of the disease, is that different for deceased versus living donors?
So the advantage is the ischemia time, meaning how long it's out of the donor before it gets in the recipient is instantaneous. It's very, very short. They're both in the adjacent operating room. The main problem is actually hooking up the anatomy. And we can get a pretty good idea with imaging to see if the liver's big enough in the right shape, et cetera. But it's really the bile ducts. You cannot do a bile duct to a bile duct anastomosis or attachment. So they actually have to do smaller bile ducts that they usually drain into the intestine. And it usually works, but the bile leak or the recurrent infections of cholangitis from living donors is higher. Overall, they do well though, but you do have a donor who has a significant morbidity and potential mortality.
Thank you.
So we have to wrap up now. I'm sorry, but thank you both. This has been really informative, and I'm really glad that everybody asked such great questions. I hope that you got some answers that you wanted. Well, maybe that not you wanted, but you got more informed. I've also been asked to remind you that to attend the clinical trial landscape and PSC session. It's going to be at 6 p.m., so right before dinner, conveniently. That's a really interesting opportunity for people to participate in the process, because the fact that our community can really be connected in this way and pool our resources for clinical trials is fantastic. So thank you again to our speakers, and thanks everybody for attending.